My name is Richard Berman, and I am one of the consultants on the supportive care team at the Christie. And I'm sorry I can't be with you in person. I'm going to talk to you. So I'm actually a palliative care consultant by birth, but my role has changed, and I'm going to tell you why in this presentation. So this is me, and in the background there is my colleague Ash, who on the picture there looks half my size, but he is actually twice my size. So it's a bit of a camera trickery there. And Ash and I lead on developments in supportive oncology at the Christie. And whilst this presentation is about supportive oncology, telling you what it is, and it's quite Christie-centric, the message I'm going to tell you at the beginning is that this is spreading now throughout the UK, which is good news. So a quick question to you, you might have to shout out, but how old do you think I am?
65.
This is backfired already. I'll tell you, I'm 52 this year. I was born in 1972. Now, in 1972, if you got diagnosed with cancer, on average, all cancers taken into consideration, what do you think the average survival was in 1972?
2 years.
2 years. Any other ideas?
5.
Yeah.
It was 1 year. The average survival was 1 year back in 1972. So it was pretty appalling. But these days, things have improved quite dramatically. And that's because of probably a lot of the things you are hearing about today in your meeting. Significant advances in diagnosis and treatments have meant that people are now living much longer. In fact, at least 6 times longer than they were 40 years ago. So what do you think, on average, if you get diagnosed with cancer today, what's your average survival likely to be?
5 years.
Say again?
5 years. 10
5
years.
years.
10.
More than 10 years. Okay, so we've gone from 1 year in 1972 to more than 10 years now. And in fact, at the moment in the UK, there are just short of 3 million people actually living with cancer, which is a lot of people. But the thing is, and I had the opportunity to talk to a government minister about this yesterday, that's going to double by 2040. So by 2040, about 1 in 13, 1 in 14 of the population in the UK will be living with cancer, which is a staggering number of people. So I'm sure you'll be hearing a lot about these today, but I said to you, the reasons why things are improving so much is because of these new treatments, targeted therapies, immune therapies. You can see me there standing next to our proton beam machine as it was being built a few years back. And the thing at the bottom there, that's a robot. It's not one of Elon Musk's new robots. It's the Da Vinci surgical robot, and we have one in our place in the Christie, and the surgeon sits remotely in a booth and operates the robot arms which do the surgery, and all of these things allow for much more precise and targeted treatment, and the results we're seeing today, with more and more people living longer and surviving the disease. And the other thing is, and this is interesting for me as a palliative consultant by background, we're seeing things that we didn't see before, even just 10 years ago. And there was a paper last year about this term, metastatic, which means the cancer's already spread, cancer survivors. Now, you wouldn't normally mix the term metastatic with cancer survivors until now, but we're actually seeing this now. And what that means is that people who, 10, 20 years ago would have died quite quickly are now, with these newer treatments, living for much longer. And a good example is in some patients with a very advanced lung cancer who would have died pretty quickly just 10 years ago. Now, with the newer treatments, immunotherapies, targeted treatments, can actually go into remission and live for several years in some cases, which is just staggering. And things are getting better all the time. In fact, even since January, there have been 15 new cancer treatments approved by NICE, the National Institute of Clinical Excellence. So it is rapidly advancing, and it's great news. The other thing that we see is, because people are living longer now, we used to talk about, and I heard Emma obviously talk about late effects before, and Emma's one of the national experts in late effects. Late effects was and is traditionally associated with people who've survived cancer. They experience side effects, adverse effects from their treatments that they had several years ago. But now, because people are living longer, even people with incurable disease, we're actually seeing side effects, even though they're continuing treatment. We're seeing side effects from treatments that they had 2, 3, 4 years ago, whilst they're now receiving another treatment for their ongoing cancer management. So that's something we didn't see before either. So it's just incredible what's happening. And I'm pleased to say that, and I'm going to like big up my own centre now, because it is good. As well as doing all this fantastic treatment, the Christie has really invested heavily in cancer support, and we have a wide range of services that support cancer patients, so that we really do strive more than ever now to help people live with and beyond cancer. But the thing is, in the UK generally, cancer care has been focusing on diagnosis, treating the cancer, and end-of-life care. But the problem with that is we've now got these growing numbers of people who don't fit into any of those categories. They might be having treatment, but they're people who live for many years, perhaps potentially with the disease on treatment. And that, you'll notice, also doesn't really talk about cancer survivorship, which I'm sure Emma said is patchy at best in the UK at the moment. So for many people who survive it, many people who are living for the disease for much longer, perhaps on treatment, we now need much more than we did. So back in 1972, when people sort of, most people died within a year, you needed oncology and you needed palliative and end-of-life care. But that is now not enough. And we need more to help people living with and beyond cancer. And I like this tsunami phrase, and I use it a lot because it's true, that there are now already a lot of people living with cancer, but that is going to increase exponentially over the next few years. And there is, if we don't do something about it now, if we don't put services together to help look after people as they're living with and beyond cancer, there's going to be a public health crisis, really, because the NHS, already at breaking point, is going to sink with all of these people. Now, Macmillan have recognised this, and they wrote a letter to the government just before the election and said, look, things are changing here, and we must make sure now that people with cancer get access to the care they need at every step of the way. So at Christie, we've been leading in the UK on something called supportive oncology, which is basically a strategy to make sure that people get the care they need at every step of their cancer journey. So what support do people need, and when do they need it? I think what's sort of clear is that there seems to be sort of these 4 groups across the cancer spectrum. So there's that box there, that first one on the left. That's people who are having treatment which is intended to cure. It doesn't always, but in the majority of cases, it does. Now, even people with curative treatment, they can get problems from the cancer and problems from the treatments, and they can have to live with the problems that those treatments cause. So they're not without their issues, and this is a growing group of people. And another growing group is the so-called incurable cancer, but it's treatable with ongoing treatment. So they may live for many years potentially. And again, you know, with treatments getting better all the time, this group is growing rapidly. There's probably in England something like 200,000 people in this group at the moment. And then there's the people are still sadly dying from cancer, although the death rate compared to the rise in incidence of cancer diagnosis, the actual rate of deaths is actually flattening as the treatments improve. But still, sadly, people die from it, and we still need to carry on providing excellent care at the end of life for them and their families. And then there's the survivorship group, the late effects group, who, again, this is a growing group as well, and they need a lot of care and support. Probably about 25% of them need a lot of care and support. Others just need some care for specific aspects of it. So we, in supportive oncology, we offer collaborative expertise on a wide range of problems that across the whole cancer continuum. So us guys in supportive oncology, we don't do the cancer treatments like Rob Metcalf, but we do the supportive treatment. So we help together with other teams in the hospital. So yeah, these are the problems we help with, and this isn't just to my team, supportive care. We do a lot of the pain and symptom management, but you know, there are other teams in the hospital that support cancer patients, like psycho-oncology, the psychology, psychiatry, like pharmacy, physiotherapy, acute oncology, and the idea with supportive oncology is that we all work together in a better way to help people manage these problems as they go through their cancer treatments at different stages. Now, I'm the UK Association of Supportive Care in Cancer, which is a new thing. I'm actually president of it, and we put together this definition, which is taken from the multinational supportive Association of Supportive Care in Cancer. But it's quite good. This I think it's sort of fairly clear what we do. Makes it fairly clear what we do. So it's about working in an integrated way with our medical and non-medical colleagues to collectively help prevent and manage the adverse effects of cancer and its treatment. And the important thing about supportive oncology, which makes it different to palliative care, is that supportive oncology it doesn't matter where you are in the cancer spectrum. You know, you can be curative, you can be incurable, you can be a cancer survivor. We will look after anyone at any point. And these are the sort of key aims: giving personalized care that is consistent with stage of disease. Now, what does that mean, consistent with stage of disease? What an example would be how we might manage pain in somebody who's in the last days and weeks of their life is not the same as how we might manage pain in somebody who's going to be living for many years with the disease, potentially. And it's certainly not the same as how we might manage pain in somebody who's survived cancer. But then the question is, well, how do we manage pain in people who are living for a long time with the disease, or those who've survived cancer? And the answer is, we don't know. And we don't know because we've left this too long. So this has all come as a bit of a shock that people are now suddenly living for a lot longer and surviving. We've got to do the research to understand how to look after them. And close to my heart is better access. I understand some people in the audience are people who've gone through cancer treatment or are going through cancer treatment. You will agree, I'm sure, that that is stressful enough. And if you have a problem, you want to get it sorted. You don't want to make a phone call and get fobbed off by the person at the end of the phone. You don't want to be told that if you've got a problem with pain or something related to your cancer treatment, to go to A&E and then have to go out in the cold, wait 8 hours or longer in your local A&E. Even getting a GP appointment is a nightmare, isn't it, at the moment? So it's important that cancer centres, even if they don't do it themselves, they need to make sure that there are services available that are easily accessed for people who they're treating. And at the Christie, we actually have a daily clinic so that people can just drop into it, so they can phone our hotline if they have a problem, and we will see them either that day or the next day latest. The other good news that I was talking to this government minister about yesterday is that what I've been talking to you about, supportive oncology, it's not expensive, because many of these hospitals, cancer centres, have a lot of the raw materials to do it, but they're just not doing it because they don't have the formula to know how to do it. Not only is it low cost, but it's high value. And it's high value because we know from research beyond doubt that if people can access these type of services, supportive services, in a timely way, then they do better from a symptom burden point of view, and it can even have a positive effect on survival. How does it reduce cost? Because we have a daily rapid access clinic, and because sorry, my little boy's coming again. You have to go downstairs, Phil. Sorry. We totally thrown now. Low cost because we see people in a lot of this is outpatient ambulatory work, and when we see them, you know, they're seen quickly. So hopefully before things have escalated, because by the time things have escalated, pain or whatever, infections, then they end up landing in hospital. And then when people get admitted to hospital with cancer, they tend to be in for quite a long time. So all of these things I've listed there help to improve the health economy. So, you know, you would hope it was a no-brainer in an NHS that's at bursting point. And in fact, he said, hasn't he, Keir Starmer, that there's no more money for the NHS, and what we have to do is work more efficiently. Well, this is a great example of, you don't need a lot of money to do this. It's about working more efficiently, and look at the benefits. There's a big study last year that looked at this. So it was done by my colleague at Clatterbridge, Dan Monnery. And basically, they looked at 8 cancer centres across England over 12 months. And they worked out that about 1.6 million was spent on delivering supportive oncology. And that translated to savings of 8.5 million. Now, any commercial organisation would look at that and go, right, we're doing it. But of course, this is the NHS, and it doesn't always happen as you'd want it to for some reason. So there we are. I'm just telling you. But we are driving development of supportive oncology in the UK, and many colleagues around the UK are getting onto this. I told you that I was a palliative care consultant. It's been a hard sell to palliative care over the years, but they're sort of finally getting the message that, you know, actually, palliative care in cancer can't really now just be about end-of-life care for people who work in cancer centres in palliative care, because the demographics changing, and we have to extend the scope of our work and translate some of those skills across different parts of the cancer continuum. Our cousins across the pond have got wind of it, and we got a nice little pat on the back there. This is the American Society of Clinical Oncology, and the Christie's the first hospital in the UK to launch an actual directorate in the hospital to actually take responsibility for this and drive it forward. It houses all the different supportive care services that I talked to you about before in the trust. And we also, as I said, provide these daily clinics, which are very helpful for people. And in fact, those of you who read the Sunday Telegraph, this is just a couple of weeks ago, they did an article about us, and it was nice to get some national coverage about it. And the other exciting thing is, because, you know, we've got to train people how to do this type of work. So we've managed to convince both major Royal Colleges now, the Royal College of Radiologists, Royal College of Physicians, that we need to start training doctors first how to provide supportive oncology, how to manage common problems that are related to cancer and cancer treatment across the whole spectrum of the disease. And we've launched a fellowship to train doctors in how to do this. And the Clatterbridge got there first, and their fellows started, I think, last week or something. And we've just appointed 3 fellows in supportive oncology at the Christie. So yeah, we just had our conference. That was a plug. So just to kind of, we have people from all over the country coming to this, from different walks of life, different areas, physios, radiographers like Emma. Although I don't think you were there, Emma. Is Emma still? Oh, next year we'll get you to speak. It was very successful, and you know, we found our tribe, because you know, there are increasing numbers of people that work in cancer centres who are getting interested in this, which is good. So thank you very much for listening.